Welcome, everyone. Thank you so much for joining this second day of the Effective Ways to Increase Vaccination Rates Symposium. We are glad you've joined us. My name is Harlow, and I'm coordinating the symposium this week, and I would just like to start with a quick Zoom note. We do welcome audience participation and audience questions today. The way that you can ask questions of our panelists is in the question and answer box, which is at the bottom of your Zoom screen. If you click on the button that says Q&A with 2 speech bubbles, the question box will pop out. You can type questions into that question box. You also will be able to upvote questions asked by other attendees if you would like to see those questions answered. The panelists will discuss and address audience questions in the second half of today's session, but please do put questions in the question box at any time that you have them. With that, I will turn over to our moderator for today, Dr. Martin Veller. Dr. Veller is a vascular surgeon and the former Dean of the Faculty of Health Sciences at the University of Witwatersrand. Thank you so much for moderating today, Dr. Veller. Over to you.
Thank you very much, Harlow, and welcome to all participants and speakers on the second day of the Executive Education Program jointly run by Columbia and by the University of Witwatersrand, looking at effective ways to increase vaccination rates. If we go anything by what we heard yesterday, this is going to be a particularly interesting day, and hopefully we will learn a lot of lessons. The important aspect is that while we are starting off with some experts in the field, the intention is that we are going to have a very strong interactive session in the second half of this talk. It is my real pleasure then to introduce the speaker this afternoon and then the moderators, and I'll do it now. Please, I'm going to just give very brief introductions. Will you please go to the Q&A section where the bios of every one of these remarkable individuals is listed. Our lecturer this morning or afternoon, depending on where you are, is Amanda McClelland, who's the Senior Vice President of Prevent Epidemics and Resolve to Save Lives at Vital Strategies, where she leads a team working on to accelerate progress to make the world safer from epidemics. The second, or the first commentator is Dr. Clare Cutland, based at the University of Witwatersrand. She is a scientific coordinator of the African Leadership in Vaccinology Expertise Consortium, known as ALIVE. This is a flagship entity within the University of Witwatersrand and was created in 2016 to create African expertise and leadership in vaccinology. The third speaker is Dr. Raji Tajudeen. Raji is a medical doctor with postgraduate qualifications in pediatrics and public health. He is currently the head of public health institutes and research at the Africa Centers for Disease Control and Prevention, based in Addis Ababa. He coordinates the establishment and strengthening of the national public health institutes across the 55 African Union member states. And then this final individual who's going to be talking in the formal component of this discussion is Dr. Ronald, Whelan, who's the Chief Commercial Officer of Discovery Health. He's a medical doctor by training, but also has an MBA and has extensive experience in clinical and corporate healthcare, spanning nearly 20 years and 25 countries globally. So welcome to all of the speakers, and again, welcome to all the participants. And may I hand over then to Amanda McClelland for her to introduce the topic. Thank you very much.
Thank you so much, and what a pleasure to be on the panel, especially with the esteemed colleagues that you just outlined. So when Wilmot approached me and asked me if I could support this session and really think about addressing the practical barriers and the best way to increase vaccination rates, I had to go back to my days as a primary healthcare nurse. So I'm a nurse by background and by training, and very focused on the practical aspects of how to get shots in arms. And so I'm going to try to focus on that very much. Sorry, I'm just having a problem with internet connection. Can you hear me okay?
At this stage, it's great, Amanda. Thank you.
Okay, Thank you so much. And so we'll focus very much on the practical barriers of getting increased vaccination rates today, but we can't really get to the practical barriers until we think about the supply chain demands at the global level. So to go through what we all know more or less as to be true, COVID continues to ravage much of the globe. This is the average daily confirmed cases per 100,000 people. See very much focused in the Northern Hemisphere there, with extremely high rates in the US and parts of Europe. And to some extent, it looks to be that the virus is sparing Africa. But what we know is the Delta virus has just been through the continent in the last few weeks, and with a lack of testing, comprehensive testing strategies, and access, that we're potentially really underestimating the impact of COVID on the continent. To some extent, global estimated excess deaths tell a similar story, but we do see some data being captured across the continent, especially in South Africa, where the excess mortality data has really shone a light on some of the challenges, not just for COVID, but on the breakdown of essential health services and the impact on estimated excess deaths. And if we carry that through to the availability of vaccine, we can really see the disparity across the regions with less than 125 million doses being estimated given on the African continents, that very small yellow line at the top of that graph, with a large proportion of vaccines currently available across Asia and North America. And the chief barrier to widespread vaccination at the moment on the continent is definitely lack of supply. But we need to think beyond supply and hesitancy around increasing vaccination rates, and that's really where I'll focus much of the discussion today. But to get the supply question, to really think about how to address practical barriers, I wanted to reflect on one of the lessons for me that I try to remember when I'm thinking through planning and supporting countries to plan. And it was during the 2016 yellow fever outbreak in Angola and DRC. This was a large outbreak, again, with a vaccine that had very limited supply. Global supplies at the time were extremely limited and were being allocated by the International Coordination Group. There was concurrent outbreaks in Brazil and a small outbreak in China. More than 30 million people were eventually vaccinated across Angola and DRC. More than 41,000 volunteers coordinating more than 56 NGO partners, and required dose-sparing strategy to reach that amount. So we had to both communicate about yellow fever vaccine, but also a change in protocol that caused some concerns around a delivery of vaccine sparing. But I want to focus in on Angola. So I supported the International Federation of the Red Cross during this response, and we were really struggling to get on top of the yellow fever outbreak. Vaccination was going relatively well. There was high rates, but we were still getting a lot of transmission, especially in the young male population. And at first we thought this was because they were more environmentally at risk, maybe they were moving around more. And it wasn't until we did a knowledge, attitude and practice survey, or the CDC conducted a survey on behalf of the cluster, and we went out and we talked to men about why they weren't getting vaccinated. And it came down to two very simple barriers. Very early in the outbreak, a well-meaning politician had promoted the vaccine, had made a speech in support of the vaccine and yellow fever control, but had said almost offhand that people should get the vaccine and then not drink alcohol for 24 hours after getting the vaccine to give their body a chance to respond to the vaccine. And so people had picked up that bit of information, and young men had turned that into, if I get the vaccine, I can't drink, and so I'm not going to get the vaccine. And the second piece that really should have been very obvious, but wasn't to us at the time, was we were setting up vaccination clinics from 8:30 in the morning until 5 o'clock in the afternoon, very much based on the community health workers and nursing schedules within the city. And most men started work at 5:30 to 6 a.m. and didn't come home until 6 to 7. And so they were missing access to the vaccine because of opening hour times. And so those two bits of information helped us overcome misinformation, but also access barriers. And we set up vaccination clinics in bars to hit both of those issues at once. And we were able to accelerate vaccination rates significantly in just a few weeks and get on top of the outbreak. So it's just to highlight that sometimes the barriers to getting vaccines in arms can be very specific. And one of the most important challenges of understanding how to roll out vaccination is to understand your micro planning and all the supply and logistics that are required, but also to engage with your communities and to keep collecting data to understand where those challenges are. And so there's some of the bottlenecks that we're going to address today. One of the ways that I like to think about this and work with the teams is really using the socio-ecological approach and thinking about barriers to implementation along that pipeline. So understanding the interpersonal challenges, really focusing on those knowledge, attitudes, and behaviors, but also the interaction of individuals in communities and what informal and social networks do to support that norming of getting vaccines, that community pressure to some extent that getting vaccines is normal, making sure that we're focusing on that norming processes and social support systems. Institutional factors and making sure that you're thinking around the organizations that are promoting vaccines, other areas to leverage institutional factors, like using businesses or a private sector. Thinking about communities and relationships, but really importantly, public policy at local, state, and national level. So we start to think about these barriers along this pipeline, but also in terms of bottlenecks at the global level, the country level, community level, and individual level. So it's quite complex thinking about that ecological model at each of those levels to make sure that you're identifying the pieces of the supply chain and the movement of vaccine from production all the way into a patient's arm. There's a number of challenges to get there. So global. We know the global bottlenecks at the moment feel insurmountable, and they're very much focused on availability and affordability. One of the biggest challenges is around poor forecasting of needs versus supply. And so we'll do a quick overview of that today. But the biggest challenge, I think, at global and down to countries, the predictability of supply. It's very difficult to do macro and micro planning when you don't know how much supply you're going to get, when you're going to get it, and what vaccine you're going to receive. So in terms of global supply, where are we? Some basic math. We need 70% of the world to be vaccinated to reach what we estimate as herd immunity to slow down transmission. Current estimates have been bumped up to almost 80 or 90% based on the Delta and emerging variants, which really increases the number of vaccines that the world needs. So some basic math. The world population at the moment, close to 8 billion people. If we need 80% coverage, that's 6.3 billion people that need vaccination. If we bump that up to 90% coverage to account for the increased transmissibility of Delta, that's 7.1 billion people that need to be vaccinated across the globe. If we need a 2-dose regime, that's around 14 billion doses of vaccine that we need globally to hit the levels that we require. So how many doses have we already given? Well, you can see on that map, it's very uneven in terms of vaccination coverage. We've given almost 6 billion doses administered so far, but 75% of that is in just 10 countries. So we still need to give somewhere between 6.7 and 8.3 billion doses. So there's still a long way to go, a lot of planning and a lot of bottlenecks to overcome. We have a 7-day rolling average of about 30 million. So at the current rate, for the number of people that we need to vaccinate, it's going to take us about another 300 days to get there, even if we're able to roll out at the current vaccination rate. And that doesn't account for hardly reached areas in challenging locations across the continent. So when we drill down and think about Africa, the data really hides the different realities around vaccine availability and vaccination pace. At the moment on the continent, we have about 128 million doses administered. That's about 1.5 million administered daily. So based on that, right, it's going to take us over 1,100 days or more than 3 years to complete the vaccination on the continent. What that's meant to do is to highlight the challenges that we need to overcome, both in terms of supply and speed. So where are we on supply? Right. Total doses produced in August 2021 is around 1.2 billion doses. In 2021, the target for approved vaccines per farmer is more than 20 billion. To reach this amount by the year's end, monthly production needs to more than triple to reach 3.7 billion per month for the remaining 4 months of the year, which is highly unlikely. And only about a quarter of that production capacity is the more preferred mRNA vaccines. And the vaccine production, again, like the supply, is not equal. That very low red bar on the graph indicates low income countries. So publicly available info shows that high income countries have already procured about 9.5 billion doses, so by far the lion's share of available doses. So what does that mean for us as planners as we're thinking through bottlenecks and how we accelerate implementation? Essentially, we should assume that COVID will remain an ongoing challenge for an unknown number of years, and will continue to provide new challenges as vaccine supply increases, but variants potentially change and dose availability fluctuates. So if we dig down into if we overcome all of the global challenges in terms of accessibility and affordability, we get vaccine supply to countries. We still have a number of bottlenecks and challenges that we need to overcome. One of the main ones is regulation. And the graph there shows the limited regulatory approvals per country. And you can see to some extent the very limited number of approvals that we currently have on the continent. Once we have liability overcome and approval overcome, we need to think about regulations on impact on trade and travel and mandating vaccines, vaccine passports, a number of legal regulation bottlenecks to overcome. One of the other big challenges that we have at the moment is data collection. How do we create line lists? How do we prove that people have been vaccinated? How do we improve surveillance for breakthrough events, side effects, and ongoing COVID transmission in the country? This has been a challenge throughout COVID and continues to be a challenge even in high-income countries such as Europe and the US. And then one of the other big challenges we're finding at country level is prioritization. Who gets which vaccine and when? We were on a call with Zanzibar a few weeks ago. Zanzibar has received, it's a very small population, under 2 million people, and they've received 7 different types of vaccines. Who do you just, how do you decide who gets which vaccine? What's the effectiveness for different variants? What's the impact on different age groups? How do you communicate that to populations, being extremely challenging on the continent with multiple vaccines with irregular supply? But I want to focus where I have had the most experience as a primary healthcare nurse and as someone that helps support countries implement, is really the implementation planning, getting from the manufacturer all the way down into vaccination outreach. And the challenges here are many, but there's something that we do regularly, especially on the continent. There's a lot of experience in running mass vaccination campaigns, a lot of strength in the polio teams and the existing vaccination teams. But it includes cold chain, which remains a significant problem with the mRNA vaccine. Not so much about getting vaccine out. We know that we can run mRNA now at normal cold chain temperatures, but that initial supply, especially at airports and main hubs, to be able to account for large volumes. The human resources that you need to pivot away from normal day-to-day tasks to undertake vaccination. This is a huge lift for most countries, but when you do a measles campaign or a polio campaign, you run it for a week to 10 days, you can absorb that shift in human resources. But if we have to continually implement large-scale mass vaccination campaigns periodically based on supply over the next 12 to 18 months, the impact on other health services is going to be significant. So thinking about human resources, not just for vaccination, but for the impact of pulling human resources away from your other critical services. One thing we continually underestimate is the commodities that you need to go along with the vaccine. So vaccine is just one part of the supply chain. Where do you get the needles, even the small alcohol wipes that you need to disinfect the arm? One thing we continually underestimate is waste management. And what do you do with the vials? How do you crush them to stop fraud or follow on? How do you manage the large number of sharps that you have, especially in rural areas? How do you make sure that you've got coverage across the whole country, especially to access hardly reached populations? And then managing disinformation and misinformation over a long period of time. So often we run these campaigns, as I said, in 2 weeks to a month. We're able to hit hard the amount of communication. We're able to manage rumors. But if you're doing this over a prolonged period of time, there's more time for misinformation and conspiracy theories to grow and to challenge communities. So thinking about this at community level, the challenges are many and diverse, and there's a long list there. How do you access congregate settings, undocumented populations? How do you manage those rumors and misinformation? How do you map access and make sure that you're managing multiple vaccine types and requirements, whether there's potential to use the private sector? Teams, again, have some experience in doing this for other vaccines, but the peculiarity of COVID increases those number of challenges and really means that we need to focus on how do we help individuals go from understanding knowledge about vaccines, belief around those vaccines, increase the intention to seek that vaccine, and then manage the logistics of scheduling an appointment, or at least knowing where to get the vaccine. And the challenge that I think presents the biggest barrier here is doing this twice. So how do we do this for individuals? Make sure that with sporadic supply over time, that we're able to maintain and build that demand. One of the challenges that we've seen as we spoke to colleagues in Ghana is they ran a big campaign, they really built up that demand, people were ready for the vaccine, but they only had 300,000 doses. So they have to build that demand multiple times, generate that intention to seek advice multiple times against supply that is a bit sporadic or continues to be sporadic. And so this pipeline of building demand and ensuring access is critical, and teams will need to think about this on a community by community basis and really link this idea of individual access with these challenges of community access and move between community and individual bottlenecks. One of the ways to do that is to really think through how to build individual enthusiasm and demand for vaccines. And this has really been a huge focus in the North around overcoming vaccine hesitancy. And to some extent, we think that this is being overemphasized, especially around the continent. It has been a real challenge. We have teams as Resolve to Save Lives working here in the US, and we feel like we are inching forward. One of our teams here in the US ran a big pop-up event, a week worth of promotion and outreach to vaccinate a total of 6 people. So it really is a challenge here in the US. It's a challenge in a number of European countries, but that doesn't really hit in until you're at 60, 70, even 80%. And so we have a long way before vaccine hesitancy becomes the major bottleneck, if at all, in the African continent. The first surveys that we have coming back from multiple countries is that vaccine hesitancy is a small percentage in most locations, but there is still a need to build up social acceptance and knowledge and trust in a new vaccine. It's important to address personal risk perceptions, but really importantly, it's about managing opportunity cost. And this is a real challenge in the continent, especially with hardly reached areas. When you need a whole family to get the vaccine, you need them to come potentially twice, and you're potentially prioritizing different age groups at different times. And this is where we'd really like to focus. The opportunity cost for families, if you're doing people over 65 first, and then you're doing people that are immunocompromised, and then you're doing people over 18, and then you're coming back to children, the opportunity cost in segmenting vaccination rollout in that way might not be the best approach in all locations. And so it's really important to think about those bottlenecks and access issues and potentially use different strategies in different locations. What the North has done and the way that they've managed their rollout probably is not the best way to address rollout plans in Africa. The opportunity costs and the logistics costs just make it too expensive, both at an individual level and a country level, to manage vaccine rollout in that way. But again, a huge challenge in terms of understanding which vaccines are available, when, and which community they suit the most. So some recommendations to help us go to the panelists and get some more practical examples from the continent and have a conversation about what comes next is to really focus on removing the practical barriers to vaccination and building resilient immunization systems. This is not going to be a one and done. Countries are going to have to implement COVID vaccine over a long period of time. As we said, at current rates, it's going to take us more than 3 years to get to the 80 or 90% level that we need on the continent. And so building resilient immunization systems and not just thinking about this as a one-off mass campaign is going to be critical. You need to understand the context both at macro and micro levels. So understand the potential opportunities and challenges at every stage in the process, and think about that socio-ecological model from policy to individual, global to local. You need to be thinking about the potential barriers in each of those phases, and really being data-driven planning. I think Angola is a great example for me, and a good reminder that you need constant data, not just on vaccine availability and vaccines delivered, but community attitude and understanding rumors, knowledge, and access opportunity costs. And so really having data-driven planning and using data effectively to inform your planning, but also change your implementation and inform ongoing policy work. Really strengthen the voices of healthcare workers, and this is key. They're the most trusted source of information in most locations, and really presenting vaccination as a social norm, something that happens regularly at the health facility, and confronting skeptical attitudes, including myth busting. We need to change the way we talk about vaccine hesitancy. This is really easily misinterpreted and can overemphasize the threat posed by low vaccine confidence, and instead be very specific about the different barriers that stop people getting vaccinated and what we can do to remove them, especially as planners. And what we say, how we say it, and who we say it to really matters. And I often reflect back on the politician in Angola who, with the best of intentions to support increased vaccination, really undermined efforts by just mentioning that you might not want to have a beer after you've had a vaccine. And so really being very clear about communication. It's very easy to alienate parts of the community, and it can really take a long time to get that confidence back. And so really controlling communication, thinking through not just how we communicate about vaccines, but about vaccine hesitancy and about COVID overall. So with that, I'd like to hand back to the panel and really look forward to the rest of the discussion.
Thank you very much, Amanda. May I suggest that, Claire, you come in directly?
Thanks very much, Prof. Veller. And thank you to Amanda for the fantastic overview and for touching on all of the very important points. I think that a couple of points that I think are essential in making sure that the vaccination rate is increased is to remove the responsibility of decisions from the individual people and rather put them on healthcare workers and on other policymakers. So ways of doing this would be to ensure that there are very clear policies available and guidelines. For example, if we consider pregnant women, there has been a lot of concern about vaccinating pregnant women, which there should be. Pregnant women were not included in the initial trials. They have now been included in some of the trials, and they have and vaccines have been shown to be safe to both the mom and the fetus, and the risk of COVID disease itself far outweighs any possible adverse events following immunization that the mom or fetus infant could suffer. So to have these very clear policies would remove the responsibility of that decision to take the vaccine or not from the person who's gone to receive the vaccine and really put it back onto the policymakers. I think that these policies need to be quite clear and stratified quite clearly according to age group, and then identify within different age groups special groups of people who may be at high risk. I've mentioned pregnant women, but also people with other comorbidities. Amanda very clearly outlined also the access to vaccines, where vaccines are given, and the challenges that are present in many places in Africa. So infrastructure challenges are often a huge shortfall and a huge stumbling block, with many healthcare centers not having easy access to water, to power, electricity supply. Obviously, water is essential for hygiene of the healthcare workers while they're busy at the healthcare centers. Many healthcare centers which could be used as vaccination sites may not be large enough to allow people to queue for the vaccine, and in an area which takes social distancing into consideration. So trying to ensure that even fairly under-resourced healthcare facilities have some chairs outside. Obviously, the weather does play into it, possibly some shading up if that is possible. That would at least increase some of the vaccination uptake rates by making people a bit more comfortable when they go through to have the vaccines. It's essential to take the vaccines to the people, and for the teams that are distributing vaccines to think broadly, to think out of the box a bit, to say where are people going to be who may not have been vaccinated, and to utilize meetings that may be taking place and other gatherings. At the moment, South Africa is heading towards a government election. So a lot of the electioneering meetings would be important and interesting places to have vaccination pop-up sites. Also other gatherings, for example, religious gatherings. So at churches or mosques and other meetings that may be taking place. The vaccine supply is obviously essential, and that does need to have, transportation needs to be taken into account when it comes to the vaccination supply, and how's the vaccine actually being given. So just one other point about utilizing meetings, pension collection points and other funds and social grant collection points are also important places to set up pop-up sites. And that would increase access to vaccination for many people who would go and collect their pensions or their social grants, and at least they could do it in one trip out. Prof. Veller, I'm going to pause there. Would you like to move on to the next panelist, and I'll come back with other comments later.
Greatly appreciated, Claire. Can we, before we go on to Raji, can I just ask all participants if they have questions that they put them into the question and answer block, that we can start thinking about ways of how we can answer those. If I then can hand over to Raji, please. Thank you.
All right, thank you. Chair, let me also join colleagues to thank Amanda for setting the stage perfectly for this particular discussion. I understand I have 10 minutes, so I bring you all greetings from Africa CDC, from John Nkegasong. Now, going back to Amanda's presentation, let me try to focus on the need to, as a way of increasing access to vaccines, to underscore the importance of tailored or locally contextualized strategy. Very, very important. And of course, where I sit as a staff of Africa CDC, a technical institution within a political organization, I will also say that as much as possible, we need to begin to use regionalization of strategy to complement multilateralism. We have seen collapse of multilateralism as far as the vaccine space is concerned. And of course, Africa CDC has also demonstrated the importance of regionalizing our approach or response to a pandemic or epidemic outbreak. And in that regard, as far as vaccine is concerned, Africa CDC actually put in place a COVID-19 vaccine development and access strategy, actually long before the first vaccine was given emergency use authorization. And this strategy has three key pillars. The first one is for us as a 55 member state, population of 1.3 billion people, to be part and parcel of the clinical trial, that will lead to the emergence of a safe and effective vaccine. We believe that being part and parcel of that trial is about confidence for our people. They will see that, yes, they've been part and parcel of this trial, and that on its own will increase uptake of this particular of vaccine. And today, I think Africa CDC has been able to do that perfectly well. We have been able to map different clinical trial sites on the continent, support them with some grant, and they've been able to play their role as far as clinical trial for some of the COVID-19 vaccines are concerned. Amanda did talk a lot about community engagement. And of course, for us as African Union, we learned a lot from the Ebola outbreak in West Africa, and much more importantly, the role of community engagement, as far as this particular landscape is concerned. Because we believe that with proper community engagement, you're able to generate the necessary demand for COVID-19 vaccine and for other vaccines. And what we've been doing, or what I've been able to do as Africa CDC, was that right from the onset of the pandemic, as part of the different technical working groups, that was put in place to drive the implementation of our continental strategy, we do have what we call the risk communication and community engagement technical working group. And this particular technical working group were able to engage the civil society organizations. They were able to engage the faith-based organizations, and they were able to engage the different community influencers from the traditional rulers, religious leaders, and so on and so forth. And of recent, they've been working closely with the sport personalities on the continent, the artists, the musicians, and so on and so forth, so as to generate the necessary demand for this COVID-19 vaccine, and also to use them to address the different rumor, that is driving the vaccine hesitancy. And one key thing for us in Africa, as far as vaccine hesitancy is concerned, is that we do not necessarily have anti-vaxxers. Most of the people who are hesitant to vaccines on the continent are people that need more information, and some of the researches or survey that has been carried out actually attest to this. And of course, community engagement also need to be informed by evidence. And in this regard, as Africa CDC, we did carry out a survey of 15 countries, multinational survey, that was late 2020, to be able to understand what is the perception of the population, the African populace, as far as COVID-19 vaccine is concerned, and use the finding of that particular study, to be able to come up with engagement strategy in terms of the different community influence that I just mentioned. And we have also used the findings from that particular survey to be able to come up with appropriate messaging targeting the different population. I completely agree with Amanda that the way you message, the message that is going to healthcare workers should be in such a way that it's not the same thing as the one that is going to the general populace. And as much as possible, I think as Africa CDC, we have been able to do that. And we have also set up what we call COVID-19 vaccine confidence project, that will be able to track the landscape as far as vaccine perception and hesitancy on the, vaccine uptake and hesitancy on the continent is concerned. The other thing I also want to mention here is the importance of political leadership. I think that we also, we have seen that play out as a very, very important tool in terms of vaccine uptake on the continent. For instance, when the issue of all this vaccine started, so what we did as Africa CDC was to engage the political leaders. And of course, this was a lot easier for us because, as I mentioned, Africa CDC is a technical institution that sits within the political organizations. So we're able to engage the ministers of health, and we're also able to engage the ministers of finance and other key ministers, and we are also able to engage the head of state and government, of some of our member states to drive some of this agenda. For instance, when COVAX started their discussion and there was this issue of giving Africa only 20% of what we need and all those stuff, the African Union was able to convey the meeting of our head of state and government, and make a case, for what we allow us to achieve population level immunity, and that further that 20% is not going to get us anywhere. And the head of state actually did listen to us, and they worked with the ministers of health and put in place what we call the AVAT, which is African Vaccine Acquisition Task Team. And through AVAT, I think we're able to complement the support that has come through COVAX. Today, through the AVAT mechanism, the continent is deploying 400 million doses of Johnson & Johnson vaccine. And that alone has been able to cover about 31% of what we need, as a continent. So we can see that political leadership also has a role to play in terms of making vaccine available, and by extension, increasing vaccination rate. Partnership is also very, very important. Without partners, there's no way we could have been able to do this alone. So it's really, really important to work together, to coordinate our efforts so that there is no duplication of the deployed efforts on the continent. For instance, as far as the vaccine landscape is concerned, Africa CDC has been able to work closely with MasterCard Foundation, and that arrangement, that partnership alone has been able to put together 1.3 billion US dollar to support the COVID-19 vaccine rollout on the continent. So this is going to make a lot of vaccines available. It's going to build us a lot of COVID-19 vaccination centers, which Amanda also clearly articulated on the importance of making sure that the vaccination site should be as close as possible to the population. Now, of course, this is one of the principles of primary healthcare system. So, and this particular partnership, again, is also going to focus a lot on risk communication and community engagement, because if you make the vaccines available and this vaccine does not get into people's arms, we've not done much. So in order to generate the necessary demand, we need to continue to emphasize and improve and strengthen risk communication and community engagement strategy. Public health workforce, very, very important. We know that whether we like it or not, the COVID-19 vaccination is something that needs to go at scale and at speed. And for us to be able to achieve this, I think we need more healthcare workers beyond what the EPI, the Expanded Program on Immunization, is used to doing. And in that regard, we have been able to deploy community healthcare workers, to be able to manage the risk communication and community engagement, because these are embedded within the community, and also deployed rapid responder to support the COVID-19 vaccination itself within the different COVID-19 vaccination centers. So public health workforce, very, very important. Data collection is key. Because without generating necessary data, there is no way we can be able to guide this vaccine rollout. And specifically in terms of monitoring adverse event following an immunization, Africa CDC is working with member states to deploy technology to be able to monitor that, as well as breakthrough infection, because we need all this information to guide our COVID-19 vaccine rollout strategy as a continent. And last but not the least, colleagues, ladies and gentlemen, Africa CDC has also launched what we call partnership for vaccine manufacturing on the continent. Of course, we can see this as medium to long term. So we need to not just look at what we're doing as COVID-19 response, but we should use that same opportunity to put in place a resilient system, that will be able to mitigate and respond better to the next pandemic. COVID-19 is not going to be the last. Surely there'll be more pandemic, but the big question is we should do better. What do we need to do better when we have another pandemic? So in that regard, we've launched that partnership for vaccine manufacturing, and we are looking at how do we change the current situation of Africa manufacturing only 1% of the vaccines that is required on the continent, and importing 99%. So, and in that regard, we've set a goal that come year 2040, we should be able to produce 60% of what we require as a vaccine. And in this regard, we are working with a lot of partners, working with our member states to support this. So lastly, let me say that as Africa CDC, we continue to emphasize on the importance of a new public health order. And this new public health order actually summarizes most of what Amanda has presented. One, the need to strengthen our health systems. There is no way you can guarantee the health security of 1.3 billion people on the continent without a resilient health system. Number two, we need to begin to invest in local manufacturing of diagnostics, of therapeutics, and vaccine. Number three, public health workforce development, very, very important. Currently, we have critical gap, and we need to address that gap. And the last but not the least, renewed and respected partnership, which key into what we are doing here today. I'm glad that Wilmot is here, so these are some of the partnerships that we're talking about. So Chair, let me stop there, and I welcome comments and reflections from colleagues on this platform. Over to you, Chair.
Thank you very much, Raji. Very insightful. Ronald, would you like to come in, please?
Thanks, Prof. Veller, much appreciated. Thanks for hosting us today. Great to be with you all. And thanks, Amanda, for teeing up the discussion and my esteemed panelists before this. Maybe a little bit of background on Discovery and South Africa to start, because a lot of my discussion is around those two contexts. So South Africa is obviously a population of 60 million people, 40 million adults. Has aimed to get through the COVID-19 vaccination program in the main between May and about February next year, aiming for population immunity. Discovery Health is the biggest private health insurer in South Africa, with 3.5 million people under administration, and partners with many of the private providers. My capacity is I've led Discovery's COVID-19 response. I've also been part of the national vaccine task team rolling out vaccines in South Africa. My previous life, I've also worked at Gavi, which has been an interesting vaccine journey as well. I think what I wanted to touch on today is our experience a little bit in South Africa and our learnings and insights from the vaccine program. So Discovery is obviously a funder. So our primary role in the system has been funding and payments for many, many years now. The vaccine program required us to take on a different role. We had to become both a funder and a provider, given some of the capacity gaps in delivering vaccines, and certainly delivering vaccines efficiently and effectively across South Africa. So over the course of the last 6 or 7 months or so, we've actually got out and set up vaccination centers across the country, have managed to deliver 750,000 vaccination doses, and have learned quite a lot in the process. In parallel with that, our involvement as part of the national program, working in collaboration with the National Department of Health and the provincial authorities, has allowed us to provide support, but also allowed us to learn around some of the challenges and constraints in rolling out effective vaccine programs. So the way we look at, or the way we've sort of distilled and synthesized vaccine programs, we see a vaccine program across four main levels. The first one, I think many of the panelists before this have articulated this probably better than I will. But the first layer is a supply layer. The supply of vaccines and indeed the supply of your consumables. There's lots of work to do around that. The second layer is the financing layer, and financing is really the oil that lubes that lubricates the system. Without financing, it's tough to make any grounds. The third layer then is the operational layer, which includes the human resources for health, includes the access points, it includes the patient journeys, and so on and so forth. And then the fourth layer is the data layer. Data, I think, as we've learned in COVID, has been a critical enabler, and it's probably unprecedented that we've got this much data on a vaccine rollout, both from a clinical perspective as well as from an operational perspective. So I guess we've found six main learnings that I thought would be might be useful to share with you today across those four layers. The first learning, we've kind of observed from the outside in, and certainly from the inside out, is that there's real power in leveraging existing assets and leveraging existing networks and capabilities. So what we found in South Africa was leveraging the private supply chain, for example, was extremely powerful. And the private sector has a well-established supply chain, good cold chain infrastructure, good transport infrastructure, and actually mobilizing that really helped move the program along very quickly. It also gave South Africa somewhat of an advantage in that by leveraging the cold chain infrastructure across the private sector, we were able to procure the Pfizer vaccine, which obviously is a very delicate vaccine, has your particular cold chain needs. So I think that was sort of your learning one, is leverage what infrastructure you've got available, think creatively around that infrastructure. Indeed, think creatively around the networks as well, around your procuring vaccines. The second learning for us is that it's absolutely critical to streamline the flow of money. What we found in the South African environment, indeed have seen this globally, is in many low and middle income countries, it's quite hard to unlock budget in cases like this. There's not typically emergency funding that's available on short notice. Budgets are very constrained. Budgets are allocated well in advance. Budgets are tightly protected. In addition to that, the procurement processes are very cumbersome and onerous. So we spend a lot of time up front, working with National Treasury, with the National Department of Health, the various provincial authorities, figuring out how do we unlock sufficient funding for this, and indeed manage to unlock some private sector funding as well as some donor funding to really get the program going. So that was lesson number 2 for us, is streamline the flow of money to get the system moving. The third learning for us was around an access learning. And the access learning for us was, think of a vaccine program as an omnichannel. Omnichannel is a common term now used in the tech landscape, retail landscapes. It basically means look for all channels to provide services to your customers or to your patients. And I think if there's anything that the vaccine programs have taught us, both in South Africa and globally, is leveraging omnichannel. We've seen vaccinations take place in sports stadiums, in cathedrals, in retail settings, healthcare settings, and so on and so forth, mobile settings. And Africa is doing some interesting stuff around drone delivery. And, if you really think your omni-channel, that helps us to get closer to the customer. So that was learning number 3. Learning number 4 was a bit of I guess a subtle learning for us, working alongside the National Department of Health. We call this learning, know your customer. As a private entity, we do extensive work around customer relationships, understanding customers, developing products and services here for customers. And we brought a lot of that experience to the fore in not only our part of the vaccination program, but also the national vaccination program, understanding deeply the needs of our customers. And I think Amanda spoke to it earlier on, where in Africa, the context is slightly different. You've got a family coming in for vaccination instead of an individual, because their transport costs. So getting an intimate understanding of your customers is absolutely critical. And recognizing the differences across different geographies, recognizing the differences across your different demographics and income groups. So certainly we learned a lot, and certainly a lot of our customers, and alongside us, our colleagues in the National Department of Health, I think you learned a fair amount there too. So that was learning number 4. learning number 5 is optimize for critical resources. Whether we like it or not, Africa and many developing countries are resource-constrained environments where there are shortages of healthcare workers. And of course, we need to be training and developing healthcare workers over the long term, and we need to be investing heavily in that. But in the short to medium term, we've got to be clever around how we use our healthcare workers and optimizing for the critical resources in the system. So nurses, doctors, pharmacists, in the system is critical to these vaccination programs, making sure that you're able to leverage a pharmacist across your multiple sites, for example, making sure that your nurse only does the critical clinical stuff, making sure that the doctor oversight is across multiple patients, and using task shifting and making sure that people are working at the top of their grades. I think it was interestingly enough, was critical for us in the private sector, and even more critical in the public sector, because across our healthcare system, we're resource constrained from a human resources for health perspective. So that was learning number 5, optimize for your critical resources. And then number 6 is a common management mantra. Our colleagues at Columbia and Walmart and team will know this better than any of us, is that if you can't measure it, you can't manage it. And as I mentioned a little bit earlier on, having access to live and reliable data, whether it's clinical data, operational data, is absolutely critical to these programs. And I think if there's one big win that's come out of COVID-19 globally, it's the ability to track infections, to track tests, to track hospital admissions, to track vaccination rates. And I think we're seeing the benefits of that data. And I think we've got to continue to invest in those data and analytic systems. And certainly from a South Africa perspective, we use data extensively across the entire system. All of our national task team meetings are governed by data. You start out with the dashboard, speak about the dashboard, track how much stock do we have on hand, how many days stock do we have on hand, where are the rates dropping off, where are the rates picking up. I think that's absolutely critical. So that was lesson number 6 for us. So, 6 quick lessons on our experience. I'm sure there's many more. Looking forward to picking those up in the open debate and discussion.
Great, thank you very much, Ronald. Before I allow the panelists and Amanda to come back at it or make comments about each other's presentations, maybe Ronald, the 7th lesson, maybe, and not so much, is that one should really be prepared. And I would like us to try and unpack that to some degree, because I mean, I think the one thing that has happened really in this country or in the world is that certainly Africa has been on the back foot, and it's not as if we didn't know that we would be hit by something of this kind of nature at some stage. But Amanda, Clare, Raji, Ronald, any comments about what any of the other speakers have made? Amanda?
I think, to reflect on that preparedness, it's the world, we knew across the world, and I don't think there was anyone fully prepared. I think there'd been a renewed focus in Africa and a new political will on the back of West Africa Ebola that definitely put a number of countries ahead of the game. And I think in terms of preparedness, vaccination, at least on the continent, was definitely further ahead than other areas. And so I am hopeful that the existing infrastructure that's been in place after decades of investment, especially by polio and the EPI teams, will put a number of countries in a good stead to roll out the campaign. But that we need to do more, and we need to do more now. This is a once-in-a-generational opportunity to really turn this political momentum into action and build the systems that we need, not just for vaccination, but the surveillance systems and the data collection systems and the lab systems that are required around that. And I think the other thing, all of the points that the panelists raised, I think are critical. but understanding that vaccination is not a silver bullet. It is definitely the way that we get out of this and we move ahead, but there's a long way to go before we reach the vaccination levels that we need. And unfortunately, that means using some of the public health and social measures that have an impact on individuals and communities effectively and in a data-driven way. So how do we, while we're focused on vaccinations, make sure that we're keeping up with maintaining essential health services? How do we use masking appropriately? How do we use social distancing appropriately? And make sure that as we pivot to focusing on vaccinations, we don't lose sight of those other things that we need to do in a multi-layered response.
Clare, did you want to respond to any of that?
Thanks for the opportunity. I think that all the comments made have been so valid and so important. And I think that what this has really highlighted is that Africa needs to be much more prepared. It needs to move from, to highlight the need for Africa to be much more self-sufficient when it comes to vaccine manufacturing, being able to think outside the box, being able to utilize the capacity and facilities that it has to be able to implement different strategies itself.
Maybe that's the question we should then ask Raji, because I mean, Amanda, while clearly there have been some areas in which there have been wins, there really is very little evidence, at least on the African continent, including the well-established environments, that we were in any position to really even get ourselves into a decent queue to access vaccines. And that, as you know, if the public health institutions had been strong and had been in a position where they had some long-term planning, I guess we would, in the African continent, have not been at the situation where, at the moment, 8% of vaccines across the world are in a country or in a continent that now makes up nearly 20%. So, Raji, your comments on that, because I mean, I think that one thing that we must make absolutely sure happens into the future is that we're not again at the tail end of this kind of problem.
No, thank you, Martin. And it's good that, I mean, you are also part of the Africa CDC family. You've been part and parcel of the journey. So I think what we have seen in the past is that we've seen a continent that tend to be reactive when it comes to, infectious disease outbreak rather than being proactive. Of course, at the end of the Ebola outbreak in West Africa in 2016, which actually catalyzed the establishment of Africa CDC. Africa is just 4 years old, and I think that actually changed the narrative as far as the way we respond to pandemic or epidemic outbreak on the continent. And in terms of trying to put in place a resilient health system. This is the reason behind the new public health order that Africa CDC and African Union continue to actually, campaign for. And we've gotten the political buy-in of the assemblies of head of state and government. And if there's anything that the COVID-19 pandemic has been able to do, it's actually allow the public health institutions to actually move as closer as possible to the political institutions. I think for the first time, people are beginning to actually realize that when you talk of disease outbreak, it's not just about medical issues alone. It has implications on the economy. It has implications on virtually every sector, of the economy, and COVID-19 pandemic has clearly demonstrated that. So for Africa CDC, we feel that this is actually a perfect opportunity, for us to put in place a resilient health system, to be able to build back better and stronger, and everybody is talking about it. For instance, when we started this discussion on the partnership for vaccine manufacturing, it actually looks something that is over ambitious, sort of. But today we've seen that a lot of progress has been made in a very short period of time. We know that Aspen in South Africa is already engaging with some of our partners from US, Pfizer, Moderna, the mRNA technology. We know that Rwanda and Senegal already signed some sort of agreement with Moderna. We also know know that Egypt, Vaxera in Egypt already signed agreement with Sinovac and Sinopharm. I think this is a perfect opportunity for us to begin to look at how do we put in place a very strong and resilient system that will allow us to do better, whenever we are faced with this pandemic. And I also agree with you, Martin, that we cannot continue to wait for what will trickle down, to guarantee our health security, population of 1.3 billion people, 55 are member states. So this is a perfect opportunity, and this is a time for us to be able to put in place a very strong, a resilient health system, in each and every member state. And part of the health system strengthening effort that Africa City is actually campaigning for is to ensure that each and every member state have what we call a National Public Health Institute, which is the NICD equivalent in South Africa, the Nigeria CDC equivalent in Nigeria, Ethiopia Public Health Institute equivalent in Ethiopia. So we are working with all the members to make sure that at least let them have such an institution, that will be able to coordinate, that will be able to shorten our decision delivery time as far as responding to our pandemic is concerned. We've worked a lot with Wilmot and the colleagues to see how do we bridge that gap of of epidemiologists on the continent. Today, as a continent, we need around 6,500 epidemiologists. All we have for a population of 1.3 billion people is 1,900. Even that ratio of 1 to 200,000 epidemiologists is something that is so difficult to achieve as a continent. So this is a perfect opportunity for us to get it right. Let me stop there. Over to you, Martin.
Thank you very much, Raji. But what you are highlighting, and which I think would be one of the real key messages that needs to come out of this environment is that we cannot let political powers be the people who eventually, again, forget about this. So it does require the profession and organizations such as yours, and in parts, I think, also the academic sector and similar organizations, that we ensure that public health systems are strengthened and that they are adequately funded, and that the training and the other outcomes that are required from all of that is there. May I just use this opportunity to slightly change the topic? And Amanda, I'm really going to aim this at you. I mean, so one of the key messages you are bringing is that we still need to achieve a wide population coverage, largely because of this concept of herd immunity. And in many ways, I'm asking the question because it is an issue in terms of access, whether that's the right message. Should we not be focusing the message on individual protection, particularly in this virus? I mean, I accept clearly that in some other circumstances, herd immunity is a concept that we've been able to use, the smallpox and the mumps and measles. But in this kind of virus, this kind of transmissibility, should we not be making it clear that people should be protecting themselves?
I think it's a good point, and it goes to the communication of how we talk about why vaccines are there. But I definitely think there's an individual protection piece and thinking about, I'm double vaxxed and I double mask. I'm in the US at the moment, and there's a lot of transmission here. And so I think we need to communicate about your individual risk and how you care for yourself. But I also think I got vaccinated in part to protect the people around me. And there's definitely a social and that impetus on vaccines protecting not just yourself, because individual risk is so different for different age groups, but protecting those that are around you. And I think in Africa with multi-generational houses, it's really important that we move beyond individual risk and make sure that we're thinking about communities. In terms of reaching herd immunity for whole populations of countries in rural areas that have a lot of ventilation, that aren't necessarily high population density, I agree, to prioritize rural communities with lower risk of transmission against, congregate settings or urban settings where transmission might be high is something that we need to think about. But those areas with lower risk for transmission also have lower access to advanced healthcare. And so it's been a challenge, I think, as we've been trying to support countries think through prioritization and a lack of data across the continent in who's being affected and how. So this idea that transmission hasn't been as bad in Africa, we haven't seen the mortality, but we don't have the data. The data in South Africa is scary to see, is that's what's happened across the rest of the continent. We just don't know. As Resolve to Save Lives, we've been investing heavily in rapid mortality surveillance. It's been extremely difficult, and I don't think we've achieved it in many locations. And so we're still missing some of the key pieces of information I think we need to make statements around herd immunity versus individual risk versus population, because we don't know the impact of the virus in terms of mortality on the continent, and also long COVID.
Absolutely agree, and I mean I'm going to ask the others to just now comment, but one of the reasons that I think that we, by protecting others, lose the political will to invest in long-term sustainability, and that's possibly an area that if the politician is not prepared to protect me by making sure that the public health is the environment, I'm more likely to want to think about that politician doing something else. But I'd be interested in other people's points of view, and Amanda, your point about what I've just said. Raji, go ahead, please.
No, thank you, Martin. I think for me and for Africa CDC, I would say we actually need the two. We need the individual protection. We need the, what they call it, the population level protection. Now, let me start with the individual level protection. For now, we are in the continent where we are faced with low level of vaccination coverage. Two, we are also seeing variants of concern, different variants ravaging our community. Three, we are seeing our healthcare system being overwhelmed. Of course, this is already, fragile healthcare system even before COVID. So under that circumstance, before we are able to scale up vaccination, individual protection, very, very important. All the public health and social measures, key, Now, for the population level, protection, we need to do this at scale, and we need to do it fast. Because the risk of not doing it fast is we continue to see emergence of new variants of concern, and that will undermine our vaccination efforts, seriously. And to summarize, you cannot have what they call it, collective health security without individual health security. So I think it's a combination of the two. Over to you, Martin.
So I wanted to maybe come in there, Martin. And
please do, Ronald.
Yeah, I'm not sure we're leveraging technology effectively enough. We've moved, even across developing markets, we've moved into an age of social media, digital access, and of course there are many pockets of the continent that don't have access, but there are many pockets that do have access. So I think there is ostensibly an opportunity to speak very individually to patients and communities in a very targeted manner. So we don't have to apply the same tools we've been applying for many, many years. We can take the new digital marketing tools that we can actually put messages into the palm of people's hands. And that doesn't mean it's a smartphone. That's a USSD messaging phone. We know that mobile penetration across Africa is exceptional. I think we could tailor our messaging across different media as well. We know that your community radio, for example, is pervasive across many, many communities. We know that there is an opportunity for I guess much more tailored responses going forward. In addition to that, I think I wanted to reiterate Raji's point. I think we've also then got to take the vaccine manufacturing, by the way. We've got issues around, in the height of the pandemic, even South Africa had a shortage of masks, a shortage of PPE, shortage of ventilators. In the vaccine program, we couldn't get fridges. So when we think about manufacturing, I think we really got to think about the full spectrum of healthcare and healthcare support services manufacturing. So it's quite a comprehensive effort that we're going to have to undertake. So one part, I guess, it's looking at this through the microscope, and the other part is looking at it through the telescope.
Great. Claire, did you want to come in with any of around this? If not, then I'm going to just go on. So the other thing, Amanda, that I think you really highlighted, and one that certainly strikes a chord with those of us in South Africa is which message and who gives that message, and this issue in terms of trusted healthcare workers. And how do we protect ourselves against those people who speak power to, or how do we protect those people who speak truth to power, and when they are being vilified because what they're saying is unpopular and uncomfortable, and we obviously have had that in South Africa. How does one make sure that message is not diluted?
I think that's the question of our age at the moment, isn't it? I mean, we looked back at 1918 Spanish flu when COVID first kicked off, and there was challenges with misinformation and messaging then, and we have them now. They just get amplified and propagated a lot more quickly. I think there's some good evidence now coming out about finding that balance between sharing knowledge and being non-biased in our scientific communication rather than trying to persuade. So I think it's knowing when we're trying to persuade, when we're trying to inform, and when we're trying to combat misinformation. Taking the politics out of it, I think, has been a massive lesson in a number of countries. And just understanding, as I said, we're supporting a team in the US. It's the first time I've supported a high-income country. And the challenges in terms of messaging here in the US and taking the politics out of it, the right message has been insurmountable. So I'm not sure that I have the right answer in terms of how we protect those voices. But I think clear, consistent information and explaining what we don't know. I think too often we try to give all of the answers to reassure. And actually what we know through good risk communication principles is saying what we don't know up front is part of building that trust, and letting people know we don't know now and this is when we think we will know is a critical piece in building that trust. So always coming out, especially with COVID, there's been so many things changing and we're learning so much as we go. Being clear about what we know right now, what we don't know, when we think we will know, and what action that individuals can take to protect themselves and their families. So it comes back to basics around good risk communication. But I think this is the, COVID is the new pandemic, but misinformation will be the pandemic that stays with us the longest. And how we inoculate communities against misinformation through improving health literacy will be the next challenge we really have to deal with.
Absolutely. Raji, maybe a question to you. I mean, what is the view that Africa CDC has in terms of strengthening this and making sure that the messages that are heard in Africa are not diluted by political expediency?
Thank you. I think that's one of the challenges we have as Africa CDC, because we are within a political organization. But I think as much as possible, Africa CDC has been able to stay above all form of political interference in terms of communication. We maintain that clarity of communication. And every week we make sure that there's a press briefing that goes out there, And in addition to that, we have enlisted the support of some of our key political leaders just to make sure that there is no political interference at all, so that everything Africa CDC is saying is guided by science and is guided by evidence. And in terms of our communication, that's going back to your earlier question to Amanda, I think we all have a role to play as far as this communication is concerned. Clarity of communication, very, very important. From the survey Africa CDC carried out in late 2020, one of the trusted voices as far as vaccine or vaccination is concerned still remain our healthcare workers. So we need to find a way of working closely with them, especially those healthcare workers who are embedded within the community. they have big role to play in terms of risk communication and community engagement. And that's only where we can generate enough demand for these vaccines and achieve the population level immunity. Over to you, Martin.
Thank you very much. I'm now going to, if there are no other comments from the panel, Clare, there was one that I wanted to focus on you, is in your experience bringing out the vaccine trials, you've obviously picked up a number of clear messages that make it people want to be participants in these and wanting to hear what is going on. What is the key message you would bring now at this stage while we are, I guess people would say, in the middle of a very, very long race?
Thanks, Prof, for the opportunity. I think that one of the key messages to bring across is that science is really guided by the evidence that's available. And as more data are collected, that evidence may change. And if, like initially, people were saying that masks wouldn't be required, then everybody's wearing masks because it's been proven, the evidence has been out to prove that wearing masks protects the person wearing it, protects the person who you're in contact with. So to bring out the message that science does move and we're guided by the evidence that is available at the time. That evidence does change as more data are gathered, and that scientists are guided by that. So what we say one day, what we said a year ago as an example, might be slightly different or very different to what is being said nowadays, because the body of evidence is changed. Yeah,
thank you. And absolutely, and I mean, there was that classic example about the whole issue around AstraZeneca in South Africa, and how that then was interpreted, and how in fact the message that came out was in fact one that really in part took the whole process backward. Can I then focus on sorry, Claire, please go ahead. You wanted to reply to that?
No, I was just agreeing with you.
Okay, great, wonderful. Colleagues, I'd like to then go to some of the questions that have been posed. The first one relates to COVAX and reaching countries in need, which includes South Africa and Zimbabwe. What can we do other than what we have been in engaging our politicians to help put pressure through volunteering with organizations like the One Campaign? I don't know if any of you would like to answer that. I guess, I mean, the question being asked by Belinda is that, yes, we have to obviously put that pressure on, and that there are many ways that we can put that pressure on, not just necessarily through single campaigns, but I think that the real pressure that I guess we will be putting on politicians must be that we need to strengthen our public health systems, that we can't afford ever to again be in the situation where we're scrambling like we have now. Anybody else? Ronald, did you want to come into that?
Yeah, I think the other point there, Martin, and I raised it in some of my points. I think as a continent and as developing countries, we've got to streamline the flow of finances as well. So I think certainly from our experience in South Africa, there were delays in our vaccine procurement because of the various procurement processes and regulations and access to financing and the different steps that needed to be navigated on that front. So we just, in many instances, couldn't mobilize quickly enough, and we certainly saw that happen across many other countries as well. And in our engagement with some of the manufacturers are raising this as an issue and saying, we've got a long list of orders, but they can't secure the financing yet. So I think, in my mind, an important precursor to the next response is making sure that there is an ability to access financing quickly, to have mechanisms like COVAX ready. I think CEPI is a great initiative. CEPI is now ready for the next response. The AU's done a lot of work on vaccine procurement. We're now ready on that front, and I think that really should help us get ahead of the curve, because with the developed countries, it is easier to unlock the sort of resources that are required for these programs. And I think there's probably quite an important role for donors to play in this as well.
But Ronald, is it not also the structure around public health emergencies? And I mean, I think in many ways the legislation is not there. Don't think that it's all that important. All of those kind of situations that make the situation very unresponsive, and one where we're not thinking about this into the future.
No, exactly, and we mustn't forget that countries themselves are complex. So countries happen. There's a federal level, and there's a state level, then there's district levels, and there are different pockets of the healthcare system that cascade through those different levels. And there's every time you jump through one of the levels, then the levels of your complexity goes up, and the red tape goes up. I mean, it was simple stuff around procurement of masks, even that central funding down to provinces, down to districts in South Africa. So I fully agree with you that we need emergency preparedness that allows that funding to flow very quickly.
Great. One of the questions that is then being asked by Sarah is, could mobile clinics be used for vaccinations in rural areas? I guess that's fairly straightforward. But the thing that's behind that is where there's no trust in official sources, government specifically, what other options are there for communications engagements around the vaccine hesitancy? Amanda?
Yeah, I mean, to Raja's point, I think we learned a lot from West Africa Ebola and the DRC Ebola outbreaks. We need to use all of the trusted sources, and in some locations that's religious leaders, in other locations it's sporting personalities, but healthcare workers remain our most trusted source. The data that we have through an initiative with Africa CDC called the PERC project has been taking longitudinal attitude surveys across 20 countries. Healthcare workers remain the most trusted source. And then we need to use other sources that are trusted in the communities. Sometimes that's teachers, religious leaders, social media influencers. Indonesia paid their top social media influencers on TikTok to promote vaccines in the same way that they would have done an energy drink. So I think you have to pick the right spokesperson for the right group, and that's different for different age groups and different locations.
Yeah, I mean, the point that was made earlier on by Ronald, we need to be inventive, and we need to think way out of what is the normal way we think about, and that people are that our population should be looked upon as customers, and how would we sell a message, and how would we make sure that they get the access to what we're looking for. Nicola has two questions in this round. One goes around the issue in terms of trust regarding politicians and the pandemic having been imposed, and rather listening to the politicians rather than to the science again. And I'd like to again, Raji, have you talk to that, and particularly in the African environment. And then the second question she has, are there measures that have been taken to directly refute the many misinformation message circulating in social media? And I guess that is obviously in part local, but is there something that's being done on a wider African scale in that line? Raji?
No, thank you. So let me start with the second question. So we've been working with partners to track these rumors, in fact, including working with the social media outlets like the Facebook itself, to track this rumor and manage them accordingly. And we have also worked with different partners within that space, including the one campaign itself, WHO, so that we have put in place a community of practice that regularly review our strategy as far as managing misinformation is concerned. Now, With the issue of politician and using science, I think as much as possible, Africa CDC, we have been able to use our convening and our advocacy power, in that regard. For instance, we have been able to bring together, working with the United Nations Economic Commission for Africa, to engage all the ministers of finance, to see the need to invest in this vaccine. In fact, the initial seed money that was put in place in that AVAD was mobilized through the Africa Import and Export Bank, largely with the support of our finance ministers, And in terms of communication specifically, I think to a large extent, most of our member states, apart from early on in the pandemic, most of what has come out from our politicians have actually been guided by science and evidence. That's to our knowledge as far as Africa CDC is concerned. And then at the outset, there was promotion of some improving interventions. But after some time, I think that has died down, a long time ago, and from that time onward, I think a lot of progress has been made, including one of the member states that was, openly denying this. So with the change of government, Africa City was invited, and we were able to, engage them and let them see reasons. So today, the vaccine has been rolled out in that particular country. They have a lot of COVID-19 vaccination centers, and as Africa CDC, we're working with them on risk communication and community engagement, just to make sure that the population embrace that public health and social measure and make themselves available for the COVID-19 vaccine. Over to you, Martin.
Thank you very much. There are no further questions currently from our participants, and I'm just going to encourage you, this intention is that this is an interactive process. But I am going to, at this stage, ask whether any of the speakers have any closing comments. I think that the real message that we're getting, and that's coming through very strongly, is that the only way that one is ever going to manage a system or a pandemic of this nature is through preparedness, and that we do know and we have very clear ideas and know exactly what should be in place. But what we tend to do is that we forget over years and we become complacent. But I think that I'd like to hear from Amanda and the other three, if you've got any closing comments.
Yeah, I'm happy to jump in terms of closing comments. I think, as I said, I think a focus on vaccination is critical at this point, but it's not the silver bullet, and we need to take vaccinations in a complete multi-layered approach, not just to COVID, but maintaining essential health services and limiting the impact of COVID on the continent. The challenges for increasing vaccination rates go beyond supply and hesitancy. They're critical challenges, and there's a number of people working globally, regionally, and at country level to overcome them. I just want to emphasize that it takes macro and micro planning, as Ronald said, telescope view and a microscopic view. It's going to be community by community, and we really need to think about the challenges that we have at all the phases of the supply chain, all the way down to individual levels. But that Africa has a solid base to build from on this. The data that we have shows that hesitancy is low, but information is lacking. Sharing knowledge is much easier than combating heavy hesitancy. And the populations are used to mass vaccination campaigns, unlike in the Northern Hemisphere. We have yellow fever and meningitis and measles campaigns regularly. Communities are used to this type of approach. And so really using that experience across the continent, showing that it can get done. And I do think it will get done, but it's going to require longer term commitment and careful planning.
Thank you very much, Amanda. Claire?
Thanks very much. So I just wanted to include 2 comments on some of the questions that were raised as well. As far as utilizing mobile clinics in community and in rural areas, yes, it's absolutely very, very useful, very worthwhile, can be done. obviously the engagement with the community leaders needs to be quite clear so that the local communities do know when to expect the outreach vehicles or mobile clinics. So they have been used quite successfully in certain sections, particularly I know in the Eastern Cape in South Africa, they've been used very, very successfully. I think that the other thing is just as far as getting messaging out, I think that messaging needs to be positive and needs to be able to show what is happening, what happens without a vaccine. I think that some of the graphics that have come out with some of the messaging about the impact that COVID has, the impact that vaccination has had on the reduction in disease burden, in hospitalizations, in deaths, has been very effective, particularly when simple graphics have been utilized. I know that some of the South African healthcare sectors have utilized an idea which came from Stanford University, and that has been well received and very clear. I think that one of the key messages is just to make sure that people are aware that science does evolve, that messages can change, and that Africa also has people, desire and drive to be able to get things done, and they have ability to get things done, to get the rollout done. At the moment, we are dependent on the rest of the world for the vaccine supply, but we need to move towards adjusting that and changing that. Thanks.
Great, thank you very much. Raji?
All right, no, thank you, Martin. I think for me, I would say that we need global vaccination plan now. We need transparency in terms of production, in terms of pricing, and in terms of distribution of this vaccine. We also need equitable distribution of this vaccine now. You know, waiting for what trickle down or being at the end of the queue is no longer acceptable. We also need a whole of society approach as far as this vaccination landscape is concerned, meaning that every hand needs to be on deck and everybody has a role to play. And I think the COVID-19 pandemic has demonstrated one thing, that we need to begin to shift away or begin to look at regionalization of efforts, you know, and see how that can complement all the multilateral mechanisms that we have in place. Thank you.
Thank you, Raji. And all of that is only possible if we have a strong Africa CDC. And thankfully, we now have you, and wish you well in that whole process. Clearly, this is the manner in which we're going to have to strengthen public health in the whole of Africa. Ronald?
Yeah, thanks, Martin. I think in addition to looking at the challenges, we've also got to build from a position of strength. And as Amanda rightly mentioned, there are many systems and processes in place, and in many respects, Africa and developing countries know how to run vaccination programs, and they know how to run them at scale. Whether it's Ebola or the childhood vaccinations, and we really got to look at those capabilities and say, how do you scale them up and how do you leverage them effectively? Community healthcare workers, another great example around surveillance. Africa's got more community healthcare workers than any other continent, and we can leverage those assets in a new way of working. I think we've got to take the innovations that have come out of COVID and accelerate them. And there have been many innovations. So COVAX, I think, a brilliant initiative. We've got to figure out how we scale that up. That can become the global pandemic response going forward. AVAX, the AU vaccination effort, led in part by the CDE and Strive Masayiwa. I mean, a brilliant initiative. How do we scale that up and use that for the next pandemic? There have been many supply chain innovations. So we've seen, for instance, helium-driven infrastructure, where a helium canister can keep a cooler box at -70 for a month. I mean, these things are just remarkable, and they really change the way we think about vaccine programs going forward, the way we think about health system strengthening going forward. We see many digital assets come into play, electronic health records. We see social media come into play. We see exposure notification apps and so on and so forth. I mean, the list goes on and on when you start to look at the innovations that have come out of COVID. So, I guess my parting thought or comment and call to action for developing countries is to really work from a position of strength, leverage the innovations to leapfrog to the next generation healthcare system. When we think about health system strengthening, I think we have an opportunity to really innovate and kind of do a leapfrog over some of the more developed healthcare systems. We don't have to do this incrementally.
Absolutely, and I mean, just imagine if those innovations had been built on a system that was already strong, we would have been in exactly that position, and that I really think is where we're going to have to, at this stage, hand over to Wilmot, who will make the closing remarks. Thank you very much, Wilmot.
So thank you very much indeed, Martin, for your very able moderating of the session. That Amanda gave a remarkably and astonishingly good overview of what it takes to in fact deliver vaccines, just given her immense experience on the front line. And it's a kind of presentation that only she can do because of the breadth of knowledge and experience across the entire platform when it comes to vaccine delivery in a very tough environment. So I'm very grateful to Amanda. I wanted to say that what I take away from her presentation is that we are going to work on this pandemic for the next 3 years in the developing world and in Africa. And that creates both opportunities but big risks as well. But it's going to be a 3-year-long effort, which really frames the work that we need to do. Our immediate challenge is to upscale supply and accelerate that in a way that makes a difference. But that the fight is essentially local. It's a local fight that we are busy with, and we need to both understand and we need to lower the barriers in an ongoing way, given the dynamic nature of this pandemic, based on ongoing research. And that research is actually social science research for the most part. And so we need to collaborate with institutions and universities in our own countries in bringing together the health science research part with the social science, which has been two different kinds of intellectual traffic for a very long time. I just wanted to mention that we are about to launch a research program both in South Africa through WITS and through in Zimbabwe through the Charles River Medical Group, which is a new group run by Terira Makadzangi, to look at what the actual vaccination experience is presently, tapping into some of the issues that Amanda raised, and also to look at vaccine safety questions. But to say that, I think that's a challenge. So that's what I take away from Amanda's presentation. Thank you to Roland. You said many things, but your point about streamlining public finance and modernizing emergency response is a very, very powerful comment. And I've worked myself with governments, and it's a heavy lift, you know. It is, the public sector is the most behind in terms of modernizing systems. We know when it comes to disasters and catastrophes, it's usually the disaster plans in cities and local municipalities that have very little to do with what happens on a provincial or state level, and very little to do with what happens on a national level. And for goodness sake, it's not that a mystery how to fix that. To have a coordinated response to, in this particular case, a pandemic, which is different to an earthquake, which is different to a flood, and not use archaic legislation, as South Africa has, for example, to tackle the pandemic. We had to modernize the legislation, modernize the regulations, and modernize the systems. In particular, making sure that there is finance required for surge capacity at institutions, and that has been on tap. and doesn't require 1,000 bits of paper that floats around. So I understand your frustration. I think we really need to learn from this lesson to do that. Innovation and the harvesting of innovations, leapfrogging, and so great point. On Clare, the point about science and how it shifts and how it defines risk, both to the person and to the community, is a very important thing. In the case of a pandemic, and the public understanding of how decisions that are based on science and how that makes a difference in terms of policy-making decisions is very, very important. So just kudos for you for making that point. In terms of Raji's contribution from the Africa CDC is to say that the CDC is a very, very young institution, but has grown massively with really great leadership. It will go through a leadership change now that John Kengasong is going to PEPFAR. And so wish the Africa CDC well in adapting to that circumstance, because that's quite a loss to the continent. But to say that what the emphasis presently is in the Africa CDC, and I work with the Africa CDC, a team of us on biosecurity training and gap analysis, is that it's all about strengthening capacity on a technical level regionally. Africa CDC sits in Addis. The action is really in the regions. And so there are 5 regions as defined by the Africa CDC. And so regional collaboration and strengthening response on a local level is in the end what makes a difference. It's a cascade. So you have high-level technical support, regional decentralization, and the localization of response. And we need to do that. Africa is a vast continent. I'm speaking to my colleagues, you don't need to know that. But it's not well understood outside of Africa. That is a very, very big place. And there are 54 countries, and that there are 2 disputed territories. And there are big parts of the continent where the state has no presence whatsoever. And that the church fills that role often in many parts. And so doing this job well is going to take, a lot of effort, and we have that opportunity. So with that, thanks. I just want to say tomorrow's session, the title of it is Vaccine Hesitancy, What Makes COVID-19 Vaccines Different. And the session will be moderated by Anya Schifrin from Columbia University. And as speakers, we have Peter Hotez. And then as panelists, we have Sarah Cooper from the South African MRC at the University of Cape and the University of Cape Town, Susan Rosenthal, who specializes in adolescent issues in medicine from Columbia University, and Stavron Nikolai, who is at Aspen Pharmacare and is the group senior executive responsible for strategic trade development. Let me just finally say thank you very much to everybody and all the participants, and to my colleague Harlow Zefting for able management of the series. And with that, thanks again, and please enjoy the rest of your day.